Right. Right on top of the hour, we are about to start. Hello and welcome. My name is Anafi Mataka. I'm from ASLM, where I function as a project lead for our United funded project on accelerating access and adoption of innovative diagnostics into national health programs, as well as a project manager for our laboratory systems community of practice funded by the Bill and Melinda Gates Foundation. Today, we are lining up another exciting session. We have our colleagues from the industry to talk about one of the most important or currently one of the hot topics that we have, which is serology. A few disclaimers as we start this session. Would like to state that we know that currently WHO does not currently recommend the use of antigen detecting rapid diagnostic tests for patient care, although research into performance and their potential diagnostic utility is highly encouraged. We also acknowledge that WHO does not recommend the use of antibody detecting rapid diagnostic tests for patient care, but again, encourages the continuation of the work to establish their usefulness in disease surveillance and epidemiologic research. We also acknowledge that there are so many questions that still need to be answered when it comes to these immunoassays. Do antibodies really confer immunity? What are the rates of seroconversion? There are also issues around interpretation, the inability to maybe detect active or from past infection. Issues around false negatives have been raised, maybe in early or in late in infection. Then people are asking whether we should be over-relying on test results rather than clinical acumen. And most importantly, there are issues of performance, particularly when it comes to prevalence of COVID-19 within certain populations, where the performance of the test is really affected, despite similar sensitivities, but in different contexts. To do this, we have lined up our colleagues from Abbott in the name Dr. Claudio Galli, the Associate Director, Medical and Scientific Affairs, Global Abbott Core Laboratory, as well as Dr. Liane Bauer, who is a Director in the Professional Services at Abbott Core Laboratory as well. Just a few reminders as we're about to start on logistics. Kindly enter your questions and comments into the chat box where we shall pick them from there. As we are about to start, I just want to also remind our dear members that we have launched the ASLM Academy, where you are able to go back to this academy and view all these sessions that we are doing. And for those that have watched them live, I think you will get instructions on how you can download your evidence of having attended this session in the form of a certificate. We encourage you to go to the ASLM Academy page, which we have shared through our listserv. We shall also share at the end of the session. And we're excited to have this on board, and we hope we will move this journey together. Ladies and gentlemen, help me welcome our first presenter today in the name Dr. Galli. Dr. Galli, over to you.
Anafi, thank you so much for this nice introduction, and thanks everybody for joining this afternoon. As you see here, the purpose is to describe something about the solutions from Abbott Diagnostics on serology. And of course, we are not dealing with everything. You see here the two different options that we do have, repeat test and lab test. We are dealing just with the latter one. You have heard before about the constraints or limitations possibly of employing both of those. So one of our tasks today would be to review which could be the performances of such tests, and also possibly to hint by which way those tests may enable, again, a better diagnosis and a better understanding of infection. So again, we do have also options on the setting in which testing may be performed. As you know, there is a huge debate about the advantages and disadvantages of having centralized versus decentralized testing. This is not a statement, of course, but it's something that may fuel discussion. My opinion is that decentralization is something that is really relevant, because the more you centralize, the more you add complexity to all the steps necessary in order to achieve a diagnosis, the more limited your diagnostic capability will do. Then, of course, a lot of other factors will play a role, that is the country size, the organization, how many kit labs there are, the instrumentation, and so on. So these should not be seen as alternatives. These are complementary, and each and every country and region will adopt the solutions that are best on their specific environment. And of course, this is also reflected about the rotation and the channels through which the diagnostic tools may be provided or acquired. There is a variety of options here. I will not go into details here. I know there will be questions at the end. I would also encourage people to submit everything they wish. We are not able to answer everything today. There will be, of course, many means to reach out to you later on. So now, if you want to deal a little bit with the actual current situation, we are a little bit, I would say, way behind. So what happened over the last few months? First of all, of course, the epidemic started. And then we initiated to have answers from the official organizations and governments, not so many, by the way. First thing that came after was from the WHO, that usually for every disease sets up this kind of classification about suspect, probable, and confirmed cases. So we will focus on the last one, which is a confirmed case. The definition is still valid, and it says that any person with the laboratory confirmation is a confirmed case. This is irrespective of clinical signs and symptoms, and this is relevant and to be taken in account, because the other definition, that is a suspect case or a probable case, are all symptomatic. So this opens the possibility of having diagnostics being used also in people that do not show signs or symptoms. So those are used, the diagnosis tools are used to confirm suspect cases, possibly, and also may be used in cases that are not so relevant on the clinical side. And this is the huge debate that is raising now in all countries, how to deliver diagnostics in patients that are not symptomatic, so are not really patients, if you wish. But the other thing that came evident over the last months is that, of course, while molecular testing is the landmark for establishing a positivity, and it's still recommended everywhere as the most suitable diagnostic tool, there is a variety of sensitivity yields according to the site in which testing will be done. This is not a secret. It is not something new. All of you know that the deeper you go down the respiratory symptoms, the higher is your likelihood to find a positive result for viral RNA. And of course, the most probable or most likely source for samples will be those ones, the nasal swabs or pharyngeal swabs. What is the end result out of that? If we take, for example, this experience reported as many other ones were from Chinese patients, you see that over the course of some 7 weeks from the onset, when you reach the 3rd week after the onset of symptoms, the likelihood of having a positive nucleic acid amplification result, if you take nasopharyngeal swabs, is limited to 1 out of 4 patients, whereas it may increase up to two-thirds of patients where you take sputum as a sample, which should not be induced but spontaneous, by the way, so early in the morning. But this still bears a limit. This is nothing strange, because it is known that in this kind of respiratory infection, as is many other, what is perceived as a viral load is not indeed a viral load, because RNA is an indirect or fake measure of viral load. But anyway, it is peaking in the very early stages and then goes down. So what happens at this stage, and this may be described, if you wish, in some images like this, in which you have the concurrency and possibly the differences in the surge and waning off of the different biomarkers. This is something general, I would say, in viral infection, may be adapted also to SARS-CoV-2, you do have a positive RNA and possibly a positive antigen. We have heard already about the, I would say, limitations for the time being of using tests for the antigen. But you do have this positivity before symptoms, and this is the main reason why people are infected before they start developing any kind of sign, and this is why the infection spreads so rapidly, by the way. Then you have a waning phase here. So the early acute phase, supposing that the onset of symptoms is in the dotted line here, then you have both viral biomarkers detectable, and usually you do not have any immune response. So if you divide the available tools between viral detection tests and immune response detection tests, you have this gap here. And in late acute phase, these two kinds of testing do overlap. So you may have an added utility according to the waning phase of viral RNA and the surge of the immunological response. Here, it is represented in a very classical way. So you have the IgM coming first and the IgG coming later. And this part of the curve is hidden. IgM is supposed to go down earlier, and there are quite a few recent evidences on that. And IgG are supposed to peak later and to stay on for several weeks or months after recovery. Of course, we do not know yet for how long and at which levels because it's too early, but we may hypothesize based on other infection that it will stay detectable for quite a long period. So what is indeed happening? How can we source if this is really true or not? We have so many contrasting evidences. First of all, we should remember that indeed already more than 2 months ago, the WHO itself did hint that when the nucleic acid assays are negative and there is a strong epidemiological link, then serology may play a role. So if you remember what we have seen before about the waning phase of RNA, especially in the high respiratory tract samples, this is the case in which serology may indeed add value. And this is where serology initially has been assessed for the employ and right use. What you see here is very short. I'm not going to describe the assay in detail. My colleagues from Abbott will be absolutely able to describe all the details on the technical aspects of the assay. The relevant things for us today are to understand that this is an assay for IgG antibodies. It's an indirect assay with anti-human IgG as a second antibody, and it uses recombinant antigen from the nucleocapsid region of SARS-CoV-2. So we are going to go a little bit in detail about these main characteristics of the assay. First thing, IgG and IgM. We have seen that the scheme before, the theoretical scheme, and then we have evidences that are not always in agreement. Just to have an example for you, this is on just 67 patients that actually were cleanly described, and you see that in this instance, IgM appeared to raise first and then to go down in frequency, whereas IgG started later and then peaked later as well. You will also note that according to that paper and the assay that was used there, and the kind of assay you are using does play a huge role on the sensitivity. Well, it appears that the maximum frequency they could reach by 6 weeks after the onset was around 35%. At the same time, RNA testing, as anticipated before, went down, and so the yield after 35 days was just 20%. But if you go to another kind of evidence, same period, same country, different setting, and different assays, it appears to be the opposite. So in that experience, actually, IgG reactivity did come up at the same time of IgM reactivity and actually was more frequently detectable throughout the course of their monitoring. They were able, they were able to monitor patients up to 51 days after the onset, and you see that it's constantly higher. If you wish, we may have also another view, and this is provided again from the same country. The difference is that the cohort is much larger, as you see, and also the assays, again, were different from the ones that have been employed in the previous papers we have looked at. So in that instance, you see that it's limited to the first 3 weeks after the onset. This is the curve and the resulting positivity for IgM that did peak at this point at about 90%, But IgG did appear first and stayed on higher rates, reaching 100% here. And if you combine the results obtained by IgG and IgM, you don't gain that much. Actually, the actual difference is maybe 1 to 2% maximum in this phase. I would say we have pros and cons. What is better, to detect IgG, to detect IgM, to detect both? Actually, I would say that the thing they should be looked at is the specific performance of the given device you're using, because, again, not assays are equal. So it is not just enough to say this assay detects IgG or this assay detects IgM, but it should be proven on real-life settings. The other issue, if you wish, is the kind of antibodies that we are detecting. As you know, that the immunodominant regions of that virus are in the nucleocapsid or the spike regions. And there are quite a few evidences that do compare reactivities towards the two. Again, the limitation here is that the assays used there are not the same, so it's difficult to extrapolate. But when you find a common pattern or something that is repeated over time, you may be decently guaranteed that indeed there is a prevalence in one sense or the other. In this experience, this comes from the US, and the assay they were using was one described and set up by them, not available outside the US. But they say that on these groups, that are the patients that were indeed positive for SARS-CoV-2, if you compare the nucleocapsid reactivity to the spike reactivity, it appears that this one was appearing earlier and possibly to a stronger level. And the same here. By the way, I would recommend very much this paper on Lancet Infectious Disease because it's very comprehensive and, of course, very well published. You see here that the same situation as before. This is put on an even scale, so the optical density for the N and the S antibodies is the same. It appears to be stronger for the N-derived antigens, again, in severe cases such as those, as well as in mild cases. This is going to be relevant because there are so many evidences so far on the direct correlation between the degree of severity of the disease and the intensity of the antibody response. And this appears to be confirmed in this experience as well. Then we are going down to the actual performance of the assay we are dealing with, the one from Abbott Diagnostics. This is what has been declared when the assay came through. So this is what you will find in the packaging of our ICU of the assay. As you see, the assay's positive agreement has been established according to the days after the onset. So no samples were positive before 3 days and a limited amount on the first week, and they said much higher the second week, and 100% after 2 weeks or more. A word of caution on that. If you go to the insert, as every insert from every company, I hope, you will find confidence intervals here because these are not absolute values. So this is the average, and there is a range that, of course, depends on the population tested and then the numbers of patients that have been tested by that device. If you wish, we do have also quite a few external evidences. The first one came from this group from the US because they started first compared to other countries to use that assay. In that experience, the cohort was quite large because they were able to enroll in their routine more than 400 patients for a total exceeding 600 samples, and that could compare the results of that given assay with the PCR positivity in the days after onset. I'm sorry this came out in a different shape compared to what it should be. So PCR is indeed in red and days after onset are in blue. I'm sorry for that. But just to go back a little bit, this is compared to days after the onset. And this is exactly what we have seen before. So you have a rate that is constant, and when you reach 2 weeks after the onset, you have a much higher detection rate compared to the previous time frames. Again, if you go to PCR, you have higher values. The reason is that PCR is performed after the onset of symptoms, so you may account for a gap or a lag between the onset of symptoms and PCR testing results of 3 to 5 days, and this accounts for the difference. Of course, there is a confidence interval out of that data as well, but it is much less than the previous data we have seen from the manufacturer because the sample size is much larger. So This, if you wish, is quite consistent with the declaration of positive agreement to symptoms or PCR testing. But then we have the other very relevant characteristic, which is specificity or negative agreement. It depends on the reference you're using. Specificity may be assessed different ways. You have specificity on potential interfering substances, and there are external data that I cannot show today because this came up later than the presentation has been set up. But anyway, in this instance, we had just one false positive out of this number of interference. By the way, the single positive, false positive, was on a CMV infection. Then we tested 199 more CMV infected samples, and just another one was positive. So it was not just related to that infection specifically. This is what is, to me, more relevant. So the true specificity is assessed when you test the population whose samples have been obtained before the start of COVID-19 pandemic. And those should be negative by definition. So what we have here is the declared value of 99.6%, which is pretty good, of course, with a confidence interval. But you also have the data coming from the outside source I was mentioning before. In that instance, what they did, they replicated more or less what is declared here. So about the same number of pre-COVID specimens were tested. They ended up with just one false positive, which is this one, just above the threshold, which is the dotted line. So the declared specificity was 99.9. But again, this should be taken with the confidence interval. So the more samples you test, the better it is in that way. But at the same time, it does provide another very valuable information, that is on the actual distribution of the negative results by that assay. You see at a glance that the vast majority, the absolute majority of samples that test negative do yield a very low signal. Actually, only 12 of those have a signal on the system that exceed a value of 0.5, the index, and the threshold is 1.4. So the number of, let's call them high negatives, if you wish, is something like 1% of results. And the ones that are nearing the threshold are just the 3 of those, 1 above and 2 below. So what's the meaning of that? It means that the assay is pretty robust, and so even if you have some conditions in which, by any given reason, calibration, instrument maintenance, any kind of potential faults that will cause a shift on the negative distribution, this is very seldom, if ever, causing an upraise in the reactives, which is important. And again, this comes back to the consideration from an API we have seen before. This is so relevant when you deal with populations in which you want to assess the presence or the prevalence of the antibodies, because actually there is no confirmation for SARS-CoV-2 serology, and the positive predictive value depends on the specificity and the prevalence, as you know, just to simulate, if you wish. I'm sorry. Sorry for that, excuse me. If you take a population of 100,000 individuals with a pretest probability or an estimated prevalence of 3%, and if you use an assay with a decent specificity, which, by the way, is the one that is attained by most rapid assays nowadays, then, of course, you may have a lot more false positives than true positives, not the fault of the assay, the prevalence that is low. If the specificity increases to 99%, of course, the PPV is higher. But again, on a population level, you're overestimating a bit, but on an individual level, you're overestimating a lot. Then with an increased specificity, then you reach the value that is about 86%, which will guarantee that 6 out of 7 positives are indeed true positive. Is that enough or not? It depends very much on the purpose of testing and on the environment you're working into. If you want to refer to what we have seen before, in the experience from the US we have looked at, they did do a small prevalence study in a population from a single city with a very low prevalence. And by the way, since their specificity was this high in that setting, they did not calculate that. This is extrapolated from those data. They would have had a PPV of 95%, which is very good. But again, this may be controlled or checked. Unfortunately, the pretest probability is often unchecked, and so it is very difficult to estimate a priori. Some people start from the symptomatic and extrapolate, telling that the asymptomatic population will be at least 10 times higher, which is not sure. We do hope to have population data from the country I'm living into, which is Italy, because the government started a campaign, a seroprevalence survey of 150,000 individuals. So when that will be over, we may have a recent and decent estimate on the rate of symptomatic towards asymptomatic. For the time being, we have just, unfortunately, a guess. Another information that may come out of this kind of assay, it is not really quantitation. This assay is qualitative as all assays that are in the market because there is no reference standard. So any unit, even if you see units on some assays, those are arbitrary units that do not compare to each other. Anyway, you do have a signal. And I'm showing you this first case of seroconversion. Again, this is the threshold. You see that values go very rapidly within 1 day from this, which may be labeled as a high negative, to a positive. And just after 1 day, the signal is more than double. So this is in accord with increasing values that have been recorded by any assay so far. Same case here. In this case, you have a barely negative result and a clearly positive after 1 day. After 2 more days, it is increasingly positive. So the question may be, how reliable may be this value compared to this? Is this just a matter of an increasing level of antibody response, or may it depend also on the relative imprecision of the assay? And we do have data on that as well, that come both from the manufacturer as usual, and also from experiences that are being conducted outside. So you see here, for example, is still from the US paper we have looked at before. They did test the same low-level reactive sample on 3 different instruments over time and did find this total variation on the signal. And then they also prepared, if you wish, 2 different pools. One that yielded a signal 20% below the threshold, and the other one 20% above. So if you wish, some sort of a critical area for that assay, they ended up with this by CLSI accelerated protocol by these very good values that were confirmed on positive controls and patient pool by a third evidence that's published, which is preprint on ClinCam right now. So any variation of the signal actually looks like it could be significant. So if you wish, in a nutshell, this is not related to the Abbott assay, but again, from that nice paper that I was mentioning before, some conclusions that may be taken, if you wish, is that both serial viral load monitoring and antibody response should be considered when making decisions about infection control measure because of this apparent inverse proportion or correlation between serum antibody and RNA. And serological diagnosis is important for patients who present late with a low viral load below the detection limit. By the way, just a few days ago, the CDC from the United States, they issued a document, an interim guidance for antibody testing, in which they reaffirmed that concept again. So this could be an added value. And by the way, also in this experience, IgG raised at the same time or even earlier than IgM. Actually, in that paper, which I could not comment for the sake of time, they did have all the different combinations. In some patients, there was a constant concomitant raise of IgG and IgM, some of those at IgG before, some of those at IgM before. And the other very interesting thing they did find is that the microneutralization titers were related to the levels of antibodies towards both nucleoprotein and RBD, which may seem strange because antibodies toward the nucleocapsid are not neutralizing, they're blocking antibodies. But at the same time, since they found the same degree of correlation, it could be hinted that any kind of strong serological response to the virus is correlated to the actual neutralization capability of that patient, which, as you know, may be assessed just by virological assays for the time being. And this is one of the evidence on this sense. You see the same agreement between AN and RBD-derived antibodies. And again here. So if you wish, as a conclusion, and of course it may be discussed later on if you wish, you have this variety or combination of potential results. When you test for RNA, this is PCR, maybe another amplification technique, but it means RNA basically, and then IgM and IgG. And the different combination may give way to a different interpretation. Of course, if you have already a positive RNA, it may look easier, but the more you go down the epidemics, the more the acute case will decrease, the more likely it will be to encounter a situation like this, in which the only viable and available biomarker will be the IgG response. And this could be, I would say, the start of a new way of interpreting data. And again, IgG testing, just to conclude, is what has been hinted by European Commission in this interim document they issued 1 month ago. And that's, I would say, not conclusive, but they opened the way to a different approach according, again, to the kind of situation they're encountering, and which is the need for testing in that specific situation. Well, this ends the presentation from my side. I hope to have kept the time within the limits. And so I think that now I will go to Liane Bauer for the second part. So I will stop sharing.
Thank you, Charles. Liane, over to you.
Yes, I'm sharing my screen. Just confirm that you can see it.
Yes, we do.
Yes, wonderful. Thank you. Thank you also from my side for attending this session, and thank you, Dr. Galli, for the nice insights into the serology testing. What I would like to talk about a bit is surveillance analytics. Why is that? And that's why I have this one sentence here on the screen on the bottom. You cannot see. When we started to this pandemic, we were more or less blind, if we are honest. But such as described by Dr. Galli just now, help us to see. Also the PCR test that was described, or an IgM test, really made us see that so that we can fight the pandemic and respond to it. But do we really just want to respond? Ideally, we want to obviously recover, emerge stronger.
Liane,
Liane, there is an echo. There is an echo in your voice, Liane.
Yes, it's clicking a bit.
Maybe there's an echo in my voice?
Yeah, it was clicking a bit. Yeah.
Hold on. How can I get, if somebody can give me...
It's cutting a bit.
I'm using earphones. Brian, is it still the same?
Looks a bit better, yeah. You can maybe at that position go on.
Looks a bit better.
Okay.
Maybe I'm speaking too loud. Maybe that's why there's an echo. Okay, so I'm trying again. So as I said, the one thing is now we can see, because we have tests available, which helps in the recovery phase, but not just recover. We want to learn, emerge stronger, be able also to more proactive act on if there might be, which we don't hold, second or third waves of infections, but that we can proactively go against them. And lastly, as I said, we want to emerge stronger and actually thrive in what many people call, or what we read somewhere, to see in time, or a test per patient. Ideally, we need to be able to connect all data points, see changes over time, within geography, or changes within certain demographies. So thinking about that, we have all thought about, yes?
Maybe you can try without a headset. Would that work? Hello?
Can you repeat what you said? Yeah, I couldn't hear you.
The sound is cutting, so maybe we can try to stop the video, or maybe try without a headset.
Okay, I can try. Let me stop the video first. Is that better now?
Okay, try and go on.
I will try again.
Yeah,
better? Let me know.
Yeah, much
looks better. Okay,
yeah.
Looks better.
Thank
Wonderful. You. So coming back to what I said, so if we want to really go through all these phases and to thrive in the end, if we want to be more proactive, we need to go beyond just seeing one data point at a time. We need to be able to connect the data, ideally look at all of it, to be able to see changes over time, changes in the geography, the demography, but also in the severity and intensity of the infection. And as you can see on the right-hand side of the slide on top, what I'm showing you here is coming from strategies for surveillance of COVID-19 from the European CDC, but this shouldn't be changing if you look most probably in any other guidelines. The reason, why do we want to see those changes in the intensity or the severity or in the geography? We want to be enabled to estimate on the one hand side the burden of the disease, but as I said, importantly to see where are those trends going towards over a period of time, up and down, so we can then inform appropriate mitigation measures, so we know what should we do about if something goes up or something goes down. And in the end, it's all about that we can act. So we're not just reporting for the sake of reporting, or we're looking at data for the sake of looking at a lot of data points, but really to act. Important then to really close the loop and to be able to do true surveillance, we need to be able to measure the impact. Meaning if I saw something going up and I act against it, can I then measure, again, going back to the monitoring piece, that whatever action I put in place made an impact. So having said this, as I said, we looked into the objectives of here, for example, the ECDC, the European CDC, looking at the different elements that should be surveyed, that should be monitored in infectious diseases. And we thought about how can we support any lab or hospital or healthcare workers in finding these trends and changes. Because currently most of the data sits in a laboratory information system, but it's very hard to just look at an LIS report or to look at a table and to really see changes. So having said this, we looked at what are the elements that we could draw out of the normal laboratory information system and then display the information in an easy visual format so that you can see the changes over time or the difference in the geography. And here you see a few metrics that we were able to develop in our system to allow exactly this visualization, and with this the easy to see changes over time or between risk groups so you can act upon it. And I would like in the next few slides walk you through these metrics and show you how these visuals look like and how they then can really help you to quicker take decisions and actions. So let me start with the first metric, where it's really just about looking at volume and results. So how can you easily track the test volume and also the incidence, so the detection rates of either, let's say, the antibody or the RNA when you use PCR testing, to quickly see what changed, let's say, from 1 month to another or from 1 week to another. The way that it's displayed in the system by pulling the data, as I said, from a laboratory information system is relatively simple. So you see one first graph where it just shows you very quickly, and here I chose, for example, an antibody test, that's a PCR test, and you can choose even, I added in here an HIV testing, depending on what assays you want to actually look at over time and how the testing volume changed. You can easily see here over each day, and this is looking over a whole month, how the testing volumes are changing. You can also see on the right-hand side easily if by a red bar, for example, did it increase or decrease versus the month before or versus the week before. So you can already draw some insights from that. But more importantly now is you want to look at, okay, I did all this testing, but how high is the incidence rate? So how high was my positive testing volume, so to say? And then you can see here on the bottom graph, the changes again over time. You compare 2 periods of time that you choose to see how much of those tests that are ran really were positively detected and how this has changed over time. And again, I just want to re-emphasize, you see here 3 different tests. You could pull in here any test that you would be in addition maybe interested about to monitor over time, because it may be helping you with further decisions. Now, but again, this is just telling us a little bit about how much did we test, how many detection rates. But if we really want to talk about surveillance, we need to understand the geographic spread. We need to understand, okay, but where did these increase of the detection rates go up or down? And we can accordingly either allocate resources or screening programs or whatever it might be. So here, the system helps you to then look at the geographic spread by splitting it further out. You can either look at the incidence or the detected tests by testing site. So that could already help to geographically pinpoint a little bit down, where do I see maybe higher infection rates or lower infection rates? Or where did I see, let's say, a positive change versus last month, or a negative trend? But again, we can argue, well, the testing site still doesn't really tell me very closely the geography of where this patient maybe came from. So ideally, I want to see it by the ordering site. So who ordered the test? So the ordering site could be, as you see on the left-hand down side, could be a doctor that ordered for it. And usually every doctor has a certain location, they sit somewhere, so you could already maybe pinpoint down which patients came to this doctor. But it also could be a blood collection site at where the blood was drawn and the order was sent to the laboratory. So you could really start pinpointing further down, not just the testing site and then the test volume and the detection rate, but you can go one step further and looking at, but where did the order come from? So it helps you to furthermore look at the geography. If the information is available in the IT system that you're using, and in some this is possible, you actually have zip codes. So obviously that helps now to even further pinpoint down in the geography where the detection rates went up or down. So you can even more pinpoint down in the geography where you either have positive trends or negative trends. And you can accordingly put your actions together and look over time also if these actions made a difference. Because as we said before, there's not just the one-time view on it, okay, did something go up or down? No, I want to see, I put an action in place, and then maybe in the next week, I want to measure, did something change? Did in that specific geography, now maybe the infection rate go down if I keep testing? What you would also want to look at, and we said this before, as one of the 4 elements that you should monitor, is the demographic spread. So you would want, and you have some examples here on the patient age, you can look at, so you can very quickly assign patient groups, and then also see how many did I test and how high was the detection rate. Again, for any test. You can use this for a PCR test, you can use this for an IgG test, an IgM test, or even, as I said, you could use it for any other parameter you wanted to look at. And then you can easily, you see in those graphs, quickly see differences between age groups. And again, you can compare it week over week, month over month, quarter over quarter, so you can see the changes. Lastly, just to come back to what I said before, what you also can do is you pull down a full report that you can actually then also download and send to any agency or any institution that you have to send your reports to due to the infectious diseases that are necessarily to be reported. So that is also possible. But I think coming back to what I said in the beginning, a table like that with all this information, and actually this table is even wider than I can show it here, is nice. But it's very hard to really see, okay, but what changed versus I did last time the report. So what we're really trying to do is to empower and to support the laboratorians or the clinicians to really not try to read through long reports, but rather to look at graphs like this that show you even visually by just color changes, or as I said, you can choose the month over month or quarter over quarter what changed, so you don't have to spend the time to go through long tables. And with this, the idea, as I said in the very beginning, is to really be able to go from the respond throughout to the recover and the thrive phase to become more proactive to be able to support in not having to read through each and every data point, but to kind of connect the dots, to be more proactive, to see changes and to act upon them and also measure the impact. That was it from my side. I hope the echo wasn't too bad.
No, the voice was now perfect after that. Thank you very much, Liane, and thank you again, Claudio. We are about to get into the question and answer. Just again to reiterate that as this platform is not a marketing platform, so we'll specifically be looking for scientifically based questions to add to the evidence around our fight against COVID as we move on. And we are glad to continue to have this discussion as well. I'll take the first question, which is coming from Z. He acknowledges that there are many immunoassays that are out there, RDTs are coming, and many people are thinking of validating these, and maybe availability of higher order tests for ELISAs would be good comparator tests rather than the PCRs. He also goes on to ask, does use of ELISA tests reduce the detectability rate compared to an RDT of specificity and sensitivity of over, say, 99%, if there is one? Maybe Claudio?
Yes, could you repeat the last part of the sentence? I had a noise in the background.
How many days would an ELISA reduce detectability rate compared to an RDT of sensitivity or specificity, which is high, like 99%?
Then that's $1 million question because we did not compare the rapid assay to the lab assay yet. Yeah. According to what I know, it will be a matter of the relative positivity for IgM, IgG, because rapid assay usually does detect both IgM and IgG, at least the Abbott one does. So in case the patient seroconverts first for IgM, there could be an edge on that side. If it's the same time, or if IgG comes first, usually the lab assay, the assay to be run in the core lab is more sensitive. So it's a balance. It's a very difficult balance to ascertain, you know. I wish I had this kind of answer. If you go to external sources, so evidences that have been generated on different solutions, usually the core lab assays are more sensitive. But again, a word of caution, there are so many different rated and so many different lab assays. So I would be very, very concerned if someone comes out with a bold statement about that.
Okay, thank you. Yeah, indeed, it's a very important question.
You're welcome.
More and more of these rapid tests are coming, and hence why we need to continue the discussions. Another question from Chidzima Ezike. He's asking, isn't there an issue with cross-reactivity with other coronaviruses? I guess he's referring to a specific test.
Yes, it is. I did answer on the chat, by the way. It's just at the bottom of the chat line. At the time the assay has been released, we did not have solid data about the cross-reactivity to other coronaviruses. Now, those are building up. I may refer to something that has been published or is in preprint now. Up to now, there was no cross-reactivity across the most common other coronaviruses, the ones that causes common cold, or the MERS. SARS is not circulating since 2003. So I would say that could be a case in which cross-reactivity could be detected, because SARS and SARS-CoV-2 viruses are very similar, but there are no more people with that infection since so many years that it is very unlikely that this will happen.
Okay, thank you very much. We also have a question from Begna Eticha from Ethiopia. And Begna says, access to serological tests is the main issue. And as we are designing a research on seroepidemiology for policy recommendation, what are your main recommendations for that?
My recommendation, if I did issue a recommendation, it will be a government officer. I may offer, if you wish, my opinion. To me, serology will be absolutely relevant on epidemiological purposes, because it will definitely enable every region in the world to really understand how much the infection did spread. Of course, serology is not perfect. It will miss samples because people with a very limited infection will possibly resolve the infection without even generating antibodies. You know, the innate immune response may be enough. At the same time, people may have a decreasing level of antibodies over time. So one of the questions that appeared on the chat was, how long will those antibodies persist? IgM, according to what we see, for a very short time frame. It may be measured in weeks, maybe a couple of months. IgG much longer, but is the much longer enough for us to state that this persistency will enable to detect people that have been infected 6 years from now, or I would say 5 years from now? We really don't know. And this is the open question, of course, but I think it may be a little bit off target. But earlier on today, I had a discussion with some colleagues, and we were remembering about the early stages of HIV testing. And we remember how difficult it was at that stage, initial stage, to be really keen in discriminating the true positives and how long the antibodies will stay and so on. Of course, that infection is chronic, so it's completely different. But I think that getting any sense out of this infection and the kinetics of the antibodies after just 4 months from the onset and the spread is way too early, unfortunately.
Okay, thank you very much. Indeed, there are quite a lot of questions around that area. I want to call upon Rosanna, who is leading some of the work with Africa CDC around serology, to make a few remarks, particularly from these few questions that have been asked around serology, how we can be better prepared. Rosanna, are you there?
Yes, can you hear me?
Yes.
Yes.
Perfectly.
Okay, well, thank you very much. These two presentations are excellent, and we really welcome these really exciting technologies to be able to measure immune response to COVID accurately, because I think our understanding of the immune response and protective immunity is still, we're still learning, right? And we need really good tools to be able to, for us to have a true understanding of what is happening in a patient who has COVID. Now, I have a couple of comments and also questions. So I think that I agree with everything that you said about the use of these tests, but and you give the sensitivity and specificity, but we know right now there is no internationally agreed on gold standard for immune responses such as IgM and IgG. So what do you think, how do you think we should come up with an immune sort of reference standard that we could, by which we could measure all these tests? And then secondly, it's great to have high throughput technology that is really accurate, and hopefully from now on we could get a true picture in many countries of how the response is going, whether it's effective or not. But there are some problems with using these high throughput assays. One is that they tend to be used in laboratory settings. So so it limits, usually these studies are done in hospitalized patients rather than community patients who may be mildly symptomatic or not. So you are getting a picture that is a little bit skewed towards more severe cases.
Yep.
Yeah, and then my last question to you is, can this test be used with anything other than serum or plasma? Because, you know, when we do big epidemiology studies, it's really hard to have a team of phlebotomists to actually take blood. And for this to be effective, I wish that we could use whole blood or we could use oral fluids. What do you think?
Actually, I'm start from the last. Thank you for the questions, which are very, very sensible. For the time being, the assay we were talking about is just for serum or plasma.
We lost your voice. We lost you there, Claudio. We can't hear you. All right. I think whilst Claudio is trying to reconnect, maybe we can take a quick question and come back. Liane, there's a question from Richard. Richard says, I'm trying to pick Richard, says, thanks for the excellent solution on how labs can use data for surveillance. However, please explain on the ALINA IQ how it can be used with LIS and where is the data shared for action, then later on measure of impact.
Yeah, can you hear me?
Yes, we can hear you.
Yeah, thank you for the question. So it's an on-premise implementation. So assuming you have one site where you want to do the surveillance itself, so you want to see the graphs where you would take actions maybe for other sites, this is where it will be implemented and where it will be pulled from the LIS. Now, it always all depends on the IT infrastructure. If other sites where the blood is collected are somehow feeding into this LIS, we can then display this information at the site where you want to see it. It is also possible to see it in different sites. It's actually web-based, so you can log in from everywhere. It's just that the implementation itself would happen on premise at one site that we would decide for. It can also, but again, that adds complexity. We can also add in information from different LIS systems. If you say, for example, yeah, I have 3 different LIS systems in my network, we can feed in information from 3 different ones and then still display them in one dashboard as I showed it. But I'm more than happy, I mean, to look deeper into that specific IT infrastructure to understand how the system will work.
Thank you very much, Liane. And it also takes us to the next question by Merdi Maklouf, who is asking, should one want further information around training resources, where do they go? Will you be able to provide us that link and resources?
Can you just tell me what specific training you are referring to?
Both for the surveillance part and for the immunoassays that Claudia has mentioned. If somebody wants further information on this, where do they get it?
Yeah, you can connect with our local Abbott team, and they will then accordingly refer either to the resources themselves or they will refer to us. But ideally, you just connect with your local Abbott team.
Okay, thank you very much, Liane. I hope Claudio is back. Claudio, you're on mute. Let me unmute you, or you can unmute yourself. You are on mute, Claudio.
Unmute.
Yeah, okay, thank you.
I'm trying to.
Yeah, you can respond.
We hear you.
You have muted, Claudio.
I tried to unmute.
Yes.
I tried to unmute.
Yeah, you can speak.
Is it okay now?
It's okay. Thank you. You can go ahead.
Eventually. I'm not too good with that. I'm sorry.
Thank you.
Just to complete the answer to Rosanna's question, again, as of now, we just have serum or plasma. Other matrices may be added later on, but not whole blood on that kind of instrument. Whole blood is the matrix on which most rabbit tests will be available for. And this is, again, one of the potential advantages of having different kind of devices available. As for the standard, everybody would love to have an antibody standard, of course. I guess it will take quite an effort from an independent organization to collect enough patients at different stages of disease and try to put up some sort of reference material that then could be provided to the different companies in order to try and uniformize the response. Point is that on antibodies, and we do have experiences already on rubella, for example, or toxo or whatever, even if you have the same vial of standard that companies may use for their secondary standards, this does not mean that the actual values measured will be the same, and I guess that Rosanna knows that very well. And that's for the time being, and then hopefully in the future it will be more clear. I'm sorry, the only quantitation we do have now is on the neutralization assays, the virological assays that are used just in P3 labs.
Thank you again, Claudio. Yes, so I think it's really almost time. I just want to give Liane 30 seconds of some last remarks. Go ahead, Liane.
Yeah, for some last remarks. No, I would just close with, I'm looking forward to work with any of you that are interested in learning more, as the question came here, to where can I get more information, more training, reach out to our team. And if you don't have a connection, I'm sure we can do it through the ASLM. If you reach out to them, they can refer you to us. And I'm looking forward to fight the pandemic with you. And as I said, we need to see what we want to fight, and looking forward to help you to see more.
Thank you,
Likewise.
Liane.
If you wish to have another session a few months or a couple of months from now, we will have more data to discuss about.
Thank you very much. I would like to also mention that visit the ASLM Academy page for more information, register and begin learning today. The Academy will offer you certificates. We have given some instructions. If you do not receive any confirmation after registering, please try to check your junk mail and follow the procedures that are there to get the certificates. We have been receiving quite a lot of requests for these. And with regards to the question on CME or CPD points, please stay tuned for more. We as ASLM, we are working together with key partners, and hopefully we'll be offering this in the near future. So I would like also to thank everybody who came in numbers for this very exciting session today. A lot was learned indeed. We look forward to our next session, another exciting one on the subject that we haven't touched really strongly over these sessions, which is really sample transport. How are we moving these samples from where they are taken to where they need to be tested? So stay tuned for the invite. We are going to be bringing that to you on Tuesday, same time, for all of you. For me, what's left to say is goodbye, good morning, good afternoon, or good evening, and good night to everyone, depending on wherever you are. Bye-bye.
Thank you so much.
Thank you.
Love that. Thank you so much.
Bye.